Hello everyone. Hi, I'm Dr. Krishna Priya, orthodontist associated with SCO, and I'm here to clear all your orthodontic questions with respect to NEET MDS 2023. So let's quickly jump into today's session. So today we'll be dealing with orthodontic study models and analysis associated with it. Yesterday was discussing about headgears, different types, and face masks. So I guess everyone had understood the concept behind it, and so that you can go through the questions easily. If you have any doubt, kindly let me know, and we can address the issue. So with that in mind, we'll proceed to today's session. Okay. So diagnostic study models, they don't need much introduction, but I'll be giving you an insight of what we are expecting today regarding the questions. So we'll be seeing about different types of mixed dentition analysis and permanent dentition analysis, and how these study analysis help in diagnosing a particular condition, and what are all the benefits of doing all these study analysis, and what are the different types of study analysis will be elicited clearly in these MCQs and the concept behind it. So these are very straightforward questions. So mostly you need to understand which concept they are and who gave them to answer the questions. So with that in mind, let's proceed to the first question. Study models are used as a reference in orthodontic cases to show shape, size, and position of the teeth as an aid in treatment planning, all of the above. The answer is very clear. It is all of the above, because without study models are the primary need in developing an orthodontic treatment. Even cephalometric comes under the secondary requirements, but the study models make the primary important requirement for the treatment planning. Generally, we use to evaluate dental arches, whether there is any asymmetry or there is any functional deviations or functional shift, whether there is any occlusal irregularities. So all these ideologies can be identified with the help of a study curve. So they are essential tool in orthodontic diagnosis and treatment planning, and also they provide a three-dimensional value, because we can't keep ask the patient to keep coming repeatedly for us to enable a bite or to see whether there is a particular overjet and overbite arrangement. The photographs, we can't rely much on them because it is not three-dimensional, and so cars play a major role in that scenario. The second question would be, according to the norms of orthodontic study models, the total height of maxillary and mandibular curves should not exceed more than. So what you're seeing, the picture you're seeing is nothing but the proper representation of a study model. It has an anatomic quotient. Okay. So do you see the tooth structure here? It forms the anatomic portion, wherein this base forms the artistic portion. So each tooth is divided into three parts, wherein the 2/3 of the entire structure will constitute to the anatomic portion, that is involving the teeth. So here the answer would be 70 mm. So the entire height of the maxilla and the mandible together with the base should be 70 mm. Why it is maintained in such a way? Because to maintain a uniformity in the different cars. So for example, if we take a pre, during, and post cars, only when they are all in ideal 70 mm, we can appreciate the difference between them without any skew in the results, and also to maintain the consistency. Yes. So they should be free from defects also that could affect the accuracy of the model. In a well-trimmed orthodontic model, the tooth part should be, just now we discussed it, it is nothing but 2/3 of the total. As you can see from the picture, the anatomic portion constitutes the tooth part, and it is 2/3 of the total value. So we have to trim the model properly, and we have to make sure that the maxilla and the mandible are in a particular ratio, and together the height should be around 70 mm. Such that 2/3 of the total height of the model should be a tooth part or the anatomic portion. The ratio between the anatomic portion to the artistic portion in a well-trimmed study cast models will be 2:1. So anatomy question forming the major area. So it can all be appreciated by seeing the study cast. And why study casts are generally used, because we need to appreciate the occlusal plane. So these study casts make sure that they take in the Frankfurt horizontal plane as a reference with which the occlusal plane is correlated, and also similarly it is associated with articulation before proceeding to the bite. So the parallelism of the maxilla and the mandibular base to the occlusal plane is an important guideline in fabricating a proper study model. Narrow-static models. Upper base is parallel to the ground, upper base is parallel to the FH plane, upper base is parallel to the lower base, or lower base is parallel to the FH plane. So the answer would be, as I mentioned previously, its upper base should always be parallel to the Frankfurt horizontal plane. Yes. They are made to represent the jaws in fixed relationship with the lower jaw positioned in the centric relation. Centric relation is the relation of the mandible to the maxilla at the most backward and the superiormost position of the condyle. The upper base that is always parallel to the Frankfurt horizontal plane. It is a standard reference plane with which the model is oriented with the upper jaw level, and the lower jaw level is maintained at the centric relation. So the proper orientation is must to identify what the bite the patient is experiencing. So nathostatics was developed by Paul Simon. So this is a fact and you have to memorize it. So around in 1960, he coined the term nathostatics, and it is a concept which involves studying the relationship of upper and lower jaw and also their position with respect to centric relation. So yeah, he introduced this concept of nathostatics and also developed a Simon retention system, which is basically used to retain the teeth in their corrected position after the orthodontic treatment. So retention is as important in the treatment plan as the treatment as such. So what I'm trying to say is that though the patient has underwent 2 years of treatment, but if he is not on a proper retention plan, then it is no use of doing the treatment, because the tooth will again go to its initial position when proper retention force is not applied. So Paul Simon has also come up with a Simon retention system using the concept of nathostatics to retain the teeth in its corrected position. And he also understood the position of the jaw with respect to centric relation. And the dentist, he suggests that the dentist should also develop treatment plan based on centric relation and occlusion rather than the position of the individual. The following is not an absolute indication for mounting an orthodontic study cast on an articulator. So the keyword here is not. And also the keyword here is an absolute indication. So whether it is very much necessary for the process to take place in order to get an orthodontic study casted on a model. So these two keywords must be taken into account while answering this question. To record and document any CRCO discrepancy, record and document the excursive path of the mandible, surgical treatment planning, classroom occlusion with severe tooth material excess of more than 14 mm. So the first three options seem sensible, but the last option doesn't seem as sensible. See why? Because it is not an absolute indication to mount an orthodontic study cast on an articulator, because in overjet is increased right here in this scenario. So there are several indications other than that. So mounting an orthodontic study cast on an articulator is just a common procedure which allows the position of the mandible with respect to maxilla, and we also have a bite with which we refer to its position. And several indications for mounting the cast on an articulator include CRCO discrepancy identification, and identifying the excursive path of mandible, and also the surgical treatment planning is done by mounting it in an articulator and making cuts so that we can see how the mandible moves when the cut is made. But in case of class 2 malocclusion with severe tooth material excess of more than 14 mm, it is not an absolute indication to mount in an articulator, because they may necessarily not use an articulator to plan an orthodontic treatment. Instead, alternative treatment options such as orthognathic surgery or tooth extraction may be more appropriate in this articulation. So when the condition is surgery, it is an absolute indication. But when we have not decided on how we are going to proceed with the treatment, then in this scenario, it is not an absolute indication, and thereby we are choosing this answer. Arch perimeter is measured with cephalogram, brass wire, vernier calipers, and occlusal radiograph. So in occlusal radiograph, though we keep the beam very close to the patient mouth for recording the radiograph, still there is a problem of magnification. Cephalogram cannot be used because it is the profile of the patient which is examined and not the occlusal area. When it comes to vernier calipers or brass wire, arch length is different from arch perimeter. So arch length, as we discussed previously, it is starting from the midpoint of central incisors to the position which is in the distal aspect of the first molar, right? This is the arch length. But arch perimeter is what is represented by the whole curve. So this arch perimeter is most usually and preferably measured with a brass wire. Why? Because brass wire has the capacity, it is very ductile, so with which we can go to each point of the tooth and correctly measure the contour of the whole arch, and then while expanding it, it will in turn be expanded in a straight line with which the it can be measured with the help of a ruler. So with that property, the brass wire is generally used for measuring the arch perimeter because it's more accurate and allows for a precise measurement of the arch perimeter. And it is preferred over other measuring tools such as cephalograms, vernier calipers, and occlusal because of its accuracy alone. Next, if the arch length space discrepancy is more than 10 mm, it indicates for correction of crowding. So when you know this chart, can answer almost 5 to 6 questions when it comes to the same category. So what is the interpretation of arch perimeter analysis? So there is a discrepancy, right? So what happens in arch length analysis? We measure the arch perimeter from the distal aspect of first molar to the distal aspect of the first molar from one segment to another segment. Then we individually measure the tooth using a vernier caliper or using compass or divider, and then we correlate it. When the tooth size is increased when compared to the arch length, then we have a discrepancy. So with the level of how much difference is the discrepancy, we decide on the extraction plan or we decide on to the treatment plan. So here, if the arch length discrepancy, that is the tooth is more than the arch length by 0 to 2.5, then we can proceed with the treatment planning, which includes proximal stripping, that is reducing zero point 0.5 to zero point 0.6 of the tooth on the mesial or the distal surface. If at all the discrepancy is between 2.5 to 5, then we have to plan regarding the extraction of second premolars. If it is more than 5, then we have to look at first premolar extraction for the treatment planning scenario. So when you understand this concept, you can answer a lot of questions with respect to this this framework. So here the arch space discrepancy is more than 10 mm. Therefore, the only option would be definite extraction of some permanent teeth. No myofunctional therapy or fixed appliance therapy is indicated. No, because they are definitely saying the words arch length space discrepancy. So immediately this table has to come into your account. Space discrepancy according to Carey's arch perimeter analysis is 4 mm. So what happens when it is 2.5 to 5 mm? We always think about second premolar extraction. So answer would be second extraction of the second premolar. So this is a method of measuring the arch length phase discrepancy by comparing the actual arch perimeter with the sum of the mesiodistal width of the tooth, as I mentioned earlier. So the discrepancy gives a better idea of how to proceed with the treatment, either with interproximal reduction or the extraction of second premolar or extraction of first premolar for relieving the crowding. Ashley House model analysis is used to predict. So generally associate your mind that Ashley Howe method is used only on the maxillary arch. So whenever you have options like mandibular arch, it doesn't work there. So Ashley Howe's method model analysis is used only on the maxillary arch. And how it is calculated? It is calculated by taking only two factors. That is the premolar basal arch width and the premolar distance, interpremolar distance. They're calling it as PMD and PMBAW. So PMD is nothing but the cusp tips of the premolar is taken with the help of vernier caliper, and then their basal arch width is taken, that is noted as PMBAW. The difference between them, with the help of the values with which the both are differentiated, we arrive at a conclusion on how to proceed with the treatment. So this is called Ashley House model analysis. It is different from Carey's analysis or the model analysis that we saw previously. So this Ashley House model analysis is based on the basal bone and transverse relationship because it doesn't go over the individual tooth, only the transverse discrepancy, premolar basal arch width versus premolar distance between them, and it calculates the basal bone transverse relationship. It compares the transfers with, okay, and thereby it can predict whether the patient has a normal, narrow, or wide transverse relationship between the maxilla and the mandible. So whenever it comes to transverse relationship and maxilla, Ashley House analysis is the required analysis that you have to do. So it will also help us in understanding the necessary maxillary expansion or mandibular expansion of both in order to achieve the proper occlusion. It is one of the several cephalometric analysis used in the orthodontic to assess the relationship between the jaws and the skull, and it also helps in the basal bone analysis and how much we can expand the maxilla and the mandibular arch. So with the same value, I said right, there will be a difference. So PMBAW is nothing but the basal arch width that is taken, and it is compared with the PMD, that is the interpremolar distance width which is taken, and they have three values to it. So if at all the ratio is less than 37%, that means the it is an extraction case. If it is between 37 and 44, then it may be a borderline case. But if it is over 44%, then it is a non-extraction case. What they are saying is that if the basal arch width, right, if the basal arch width is smaller when compared to the premolar width, then arch expansion is not possible because already the basal arch bone is properly expanded and it is in the position. But if the basal arch width is more and the premolar distance is less, then in those scenarios, the arch expansion is definitely possible. So in Ashley House analysis, they give two variables. One is that whether the difference which is higher, PMBAW or PMD, based on which they'll decide whether arch expansion is possible or not. And also, secondly, they have some values when they do a ratio of PMBAW with PMD or with total tooth material, which will give us a concept of whether an extraction is required in the scenario or we can go about with non-extraction or it falls in the borderline. So this analysis is very much helpful in identifying the basal bone transverse method and also whether the patient needs an extraction or can proceed with non-extraction case. So since the value here represented is 44, it falls under the borderline case. So the answer would be borderline. PMBAW percentage is very important parameter in determining the need for maxillary expansion or the mandibular constriction. So as we mentioned earlier, when the PMBA, that is the basal arch width, is increased than the premolar distance, then arch expansion is not possible. But whereas it is the basal arch width itself is decreased, then the arch expansion is possible. A 14-year-old boy with a class 2 division 1 malocclusion, which model analysis is used to decide whether to do extraction or not? So we've seen two cases wherein in both the cases that we were talking about, extraction or non-extraction, right? Just Carey's analysis or Ashley House analysis, or even uh, both scenarios represents with the extraction or the expansion case. So here the answer would be Ashley House analysis. So in the previous scenario, we can also look into this classification which delineates between the permanent dentition model analysis and the mixed dentition model analysis. Generally, in mixed dentition model analysis, the concept behind is that in mixed dentition, we are looking into the aspect wherein we have permanent central incisor, lateral incisors, and permanent molars in the permanent first molars in the upper and lower arch. So the patient would be around 6 to 7 years of age. Usually, the mixed dentition model analysis takes in the value of either the sum of the mesiodistal width of maxillary central incisors and lateral incisors, or sum of the mesiodistal width of the lower central and lateral incisors, and with the help of that sum, they'll try to identify the size of the permanent tooth and they'll examine with the arch space present. So they can predict whether the patient would end up with a crowded arch or the patient would have an expanded arch. So that is what mixed dentition analysis. Some of the mixed dentition analysis will compare to a chart which is prepared. So based on the value obtained from the mesiodistal width of central, upper or lower incisors, they'll have a chart so that with that they can identify, okay, this much space is available. So the permanent two premolars and would be of the similar size. Permanent canine and premolars would be of the similar size. So either they'll compare with the chart, or they'll compare with the radiographic measurements, or they'll compare with the opposite permanent tooth in the other segment. This is how mixed dentition analysis works, and usually it includes Moyer's mixed dentition analysis, Tanaka Johnston, Nance mixed dentition analysis, and radiographic method by Hukaba's mixed dentition analysis. When it comes to permanent dentition analysis, the first one we have to see is about Bolton's. So, what does Bolton's do? Basically, they calculate the mesiodistal width of molars starting from this side. They calculate all the mesiodistal width of the molars, upper molar to molar, that is 12, and lower molar to lower molar. And then they make a ratio between the maxilla and the mandible in such a way that they come to a particular value. So whenever the value comes below the certain value or above the certain value, then we would know that which jaw has an excess with compared to the opposite jaw. Okay, they make a ratio between mandibular 12 tooth to maxillary 12 tooth, and with the receiving value, the receiving number, they compare it to the registered number. For example, like 91.7. So with that, they'll compare. If it is less than that, then there will be maxillary excess. If it is more than that, then there will be mandibular excess. So with the help of that ratio, they'll come up with the conclusion. So that is called as Bolton's analysis. And we've already known about Ashley House analysis and also Carey's analysis. We have Pond's analysis, which we'll discuss in the further slides. We also have arch perimeter analysis, which we discussed earlier with the help of a brass wire. We take an arch wire and then identify the arch perimeter. We have Linderhart, Corcus, and also the Peck and Peck index. So these are the permanent dental model analysis, and whereas that is the mixed dentition model analysis. So here the answer would be extraction or not, right? So the answer is Ashley House analysis. So this is the representation of the Bolton's analysis. See, they've given sum of mandibular 12 divided by the sum of maxillary 12. So you'll get an answer, right? So if that answer is less than 91.3, then it is maxillary excess. But if it is more, then it is called mandibular excess. Similarly, for anterior, that is mandibular 6 by maxillary 6. If it is less than 77.2%, then we have maxillary excess. Or if it is more, then it is called mandibular excess. You should just know these values and then it will be easier. Whenever we know that one particular arch is in excess, then we can do extraction only in that arch in order to bring it into a proper harmony. Okay, that is the whole concept behind this. I mentioned all this. In Pond's analysis, for a given width of maxillary incisors, the arch width at the molar region should be. So Pond's analysis, they are measuring for the arch width in the molar region. Here, they are taking into consideration only the width of maxillary incisors. So they have a formula. So they are calculating the incisors into 100 divided by 80 for the premolars and divided by 64 for the molars. So here the question was molar region. So the answer would be 64. So imagine for Pond's analysis, we are just taking into consideration the mesiodistal width of the maxillary incisors and then correlating them with 64% and 80% to identify the value of the premolar and the molar respectively. So for molar it will be lesser 64 and for premolar it will be 80. It is a cephalometric analysis used in orthodontics to evaluate the transverse dimension of dental arches, and it will also help in identifying the width of maxillary incisors with respect to which the premolar and the molar transverse width can be measured. Pond's premolar index formula is, just now we discussed, right? It's incisor width into 100 divided by, for premolars it is 80 and for molars it is 60. So the answer would be B. Which of the following analysis helps in determining the disproportion in the size between maxillary and the mandibular teeth? So here, just now we went through this analysis. The disproportion, that is the ratio between upper arch and the lower arch, which is higher or which is lower. So that is nothing but Bolton's analysis. We've discussed it in detail just previous slides. So, okay, I think with this we get a short summary. You should not get confused at all. Initially, we saw about arch perimeter analysis, then Carey's analysis was shown, and then we went to Ashley-House analysis. In Ashley-House, we were talking about the extraction, whether extraction is there or whether expansion can be done using the premolar basal arch width with premolar distal width. Okay, so whichever is higher than the other, then we can decide on the fact whether expansion is required or not. And also we also had a range. 37%, 37 to 44 was borderline, greater than 44 means non-extraction. So this is Ashley House. And before that, with Carey's analysis, we just measured the arch perimeter and individual mesodistal width of the tooth. And if it was between 0 to 2.5, interproximal reduction, 2.5 to 5, we had second premolar extraction, greater than 5, we had first premolar extraction. So Carey's analysis was this. Ashley House analysis, we were talking about expansion and the values associated with it. Then we were discussing about Bolton analysis, which is nothing but the ratio of the maxillary tooth to mandibular tooth, maxilla 12 and mandibular 12. It goes by the formula sum of mandibular 12 divided by maxillary 12 into 100. So if it is above if it is the value is coming below 91.3%, then the maxillary excess is there. If it is above, it is a mandibular excess. Similarly, for anterior ratio, the value is 77.2. So this comes about Bolton's. And now then we were discussing about Pond's analysis. In Pond's analysis, we are seeing this mesodistal width of the incisors with respect to the premolar width and the molar width. If it is premolar, then it is 80, and molar width means it is 60. So this is the short version of all the analysis we've discussed till now. Coming to peck and peck analysis, the mesodistal dimension of which teeth is taken into consideration. So in peck and peck, it is always the lower incisor, but in Pons, it was the upper incisor. So you make a chart and you be very clear on which analysis concentrates on which tooth to provide the possible results. Don't get confused in this scenario. So mesodistal dimension of lower incisors is a very important measurement in peck and peck analysis because it will help in identifying the lower arch form and also the proportionality of the lower teeth. So lower incisor is compared with the mesodistal dimension of the upper incisor to determine the tooth size discrepancy. That is the peck and peck analysis. It includes values such as intercanine width, intermolar width, arch length, and depth, Bolton's ratio, and such. It also helps in the assessment of arch length and arch form, tooth size discrepancy, and it also helps in the treatment planning. The following is one of the mixed dentition analysis. So we know Bolton is a permanent one, Carey's is a permanent one, Ashley House is also a permanent one. So the answer will be Tanaka Johnson, which we've already seen. Moyers, Tanaka Johnson, Hakaba, Nance mixed dentition analysis falls under the mixed dentition analysis. So this is used to predict the size of unerupted permanent canine in premolar, and it was developed by George Tanaka and James Johnson. So they combine the mesodistal width of the unerupted permanent canines in premolars, and the formula is nothing but 0.5 into mandibular incisor width plus 11 mm for female or plus 12 mm for male. They just take only the value of mandibular incisors and they multiply it with 0.5 mm, and they add 11 mm for female and 12 mm for male in order to figure out the mandibular canine and the premolar width. So it will help us in the space which is present for the permanent canines and premolars to grow and identify whether future crowding will be there and whether extraction is necessary to go about the orthodontic treatment. So this analysis is very useful in determining whether there is adequate space in the dental arch for the permanent tooth to erupt into the oral cavity. Which in mixed dentition analysis is not used in the mandibular teeth. So Moyers, Makaba, Tanaka and Johnson and Howey's analysis. The answer would be Howey's analysis. This because in remaining areas we use the mesodistal width of the lower incisor for the mixed dentition analysis. So Howey's analysis we don't use that. Because it is not a mixed dentition analysis and therefore it doesn't apply to either a maxillary or mandibular tooth. Rather, it is generally a cephalometric analysis that evaluates the relationship between the teeth and the basal bone structure. Okay, but Moyers or Huckabee, Tanaka Johnson are all mixed dentition analysis that predict the size of unerupted tooth and estimate the amount of size needed for eruption, as I've already mentioned. So this, since Howey is not at all a mixed dentition analysis, it doesn't apply in the question. In which one of the following mixed dentition analysis of deciduous dentition, there is no use of radiography. So as I was already discussing with you, sometimes they take a radiograph and measure in the radiograph the size of the permanent tooth and compare to the arch length present in order to find out whether there is enough space for the permanent tooth to come out. So they're asking in which one of the following mixed dentition analysis there is no use of radiograph. It is Moyer's analysis because in others like Huckaba and Hicks and Oldfather, in both they use radiographs for the measurement. Only in Moyer's they don't use it. They take up the value by using the mesiodistal width of the incisors. One minute. One minute. Actually, it went before, so I'm not sure which is going. Let's start from this. So analysis of Desidee's dentition, there is no use of radiograph. As we mentioned, it is Moyer's analysis. And what does Moyer's analysis require? The measurement of mesodistal of the erupted permanent mandibular centrals and laterals. So they use lower mandibulus, permanent centrals and laterals to identify the predictable width of permanent canines and the premolars. And it was described by Henry Moyer in 1958, and it's widely used in order for the mixed dentition analysis. The predicted combined mesodistal width of unerupted tooth is used to estimate the amount of space required for their alignment as well as to determine some areas for it. So it's very accurate and it is performed on the individuals which is generally between 9 to 12 years of age because their incisors and the molars should have been well developed for our incisors should be well developed for this analysis to take place. Which orthodontic analysis uses the dimensions of lower anterior teeth to predict the dimensions of the upper and lower posterior teeth? It is Moyer's analysis. Because the key word here is that lower anterior teeth is used. Lower anterior teeth is used to predict it. But the keyword is both upper and lower posterior area and the tooth dimension is identified. So Boyer's analysis is the only mixed dentition analysis. Bolton's analysis is a permanent one and Carey's analysis is also a permanent one. Nixon and Oldfather use a radiographic technique, so it cannot be taken into account. So the answer would be Moyer's analysis. The differences in completing a Hickson, Oldfather, and Moyer's analysis of the following, which would not be correct. So, read the question carefully, which would not be correct. The Moyer's analysis requires the eruption of the mandibular arch only. It is similar to Hickson, Oldfather, mandibular permanent centrals and laterals analysis and require radiograph. Stanley Kerber revision. No. The Hickson Oldfather require an eruption of mandibular and revised Hickson Oldfather predicting graphs in mandibular permanent centrals and laterals. The Hickson Oldfather analysis requires the measured Stanley Kerber methods will give the best prediction of the tooth space available in all the four posterior quadrants. Or the Moyer's analysis requires the measurement of space available in the four posterior quadrants. So the answer would be which would not be correct. So the Hickson Oldfather analysis, they require the measured Stanley Kerber models which will give the best predictable tooth size and available all the four posterior quadrant sites followed by Tanaka, Johnson and Moyers. So them stating that Hickson is better than Moyers is the wrong information here because both Hickson and Moyers they are used to predict the size of unerupted tooth and the amount of space required for them for their alignment. While the Staley-Kerber method is used to assess the amount of space available for the alignment of tooth. So both are different. One is used for prediction and one is used for the assessment of the available area for the alignment. So all the three are not same and they are not always using the predictable method of identifying the space enough for the permanent tooth to erupt. Kelly and Kerber is revised analysis of Hickson and Oldfather analysis as you have just now seen. So in Staley and Kerber, we'll just identify the space which is required for the alignment of the permanent tooth, and it was one of the earliest and most widely used methods for predicting tooth size and the assessment of the space. It's just a modified version of Hickson-Wolff further analysis that includes additional measurements of the tooth and the arch dimension, and they also help in identifying the extraction is required or not. Tanaka-Johnson analysis is used to predict one will give the best result. So basically, the size of the unerupted tooth, right? It is given by Stanley and Kerber. So that is very much best predicted by this analysis. The Tanaka-Johnson is used to predict the size of unerupted permanent teeth, which is based on the size of the mandibular incisors, and it is also used as the space assessment tool for the future alignment, and it is based on the measurement of the mandibular permanent incisor, including the width and the height. This sum is used to estimate the combined width of maxillary and the mandibular canine and the premolar width. While the mandibular permanent incisor height is usually estimated the combined height of the maxillary and the mandibular canine and the premolar height. So the basic is that lower incisor mandibular teeth is used for the calculation for the permanent upper and the lower canine and premolar teeth. All of the following assumptions are considered true when doing the space analysis for calculating the space discrepancy. So the key word here is except. So everything is true for space analysis except all permanent teeth will develop normally. Correlation between the size of mandibular incisor and the succarineous teeth. Prediction table most valid for all the population. Arch dimension remains stable through the course. So everything is almost true, but except the prediction table is most valid for all the population, and not all analysis uses the prediction table also. So for calculating the space discrepancy in ortho, several assumptions are considered true, and except the last one, because the prediction tables are based on the data collected from a particular population, so they can only be true to that, and they can never be true to almost all the population, and therefore it is a wrong option here. Okay. With this, we come to the end of today's session with respect to all kinds of model analysis, and tomorrow we'll be seeing about the retention and relapse. If you have any doubts regarding the same, can kindly put up in the comment section so that I can identify that, and we'll let you know. So today, I think you underwent a lot of confusions with respect to which analysis to use for what. It's very simple. Just be basic and first divide them into mixed dentition analysis and the permanent dentition analysis. Okay, and then understand each analysis better and understand how one analysis is different from the other and what is the key feature of it. We've discussed about 8 to 9 analysis, so stick with that. And if you know all these things, then in this particular category, whatever questions or MCQs comes, and I'm definitely sure that you may be able to answer it. So if any other doubts, let me know. I can address all the doubts that you have regarding the issue. Or else we'll close the class today and we'll meet tomorrow with the topics involving retention and the relapse.